So thanks to everyone for joining us, and we're very lucky to kick off with Dr Fiona Crawford-Williams, who is here with us, and she is going to be talking to us today about research and infrastructure priorities in cancer survivorship in Australia. And Fiona has a background in health psychology. She completed her PhD in 2017 before undertaking a postdoc position with Cancer Council in Queensland. So shall I hand over to you, Fiona? Thank you.
Thank you very much. I'll just pop the PowerPoint up and hope everyone can see that. So I'd just like to thank the PoCoG team for inviting me to talk to you all today. I'm Fiona. I'm currently a research fellow at QUT, and I'll be talking about a project that I did in collaboration with the COSA Survivorship Group, which developed research and infrastructure priorities for cancer survivorship specific to Australia. And before starting, I'll just also like to acknowledge, in the spirit of reconciliation, acknowledge and thank the Turrbal and Yagara people of the lands on which I currently live and work, paying respect to their past, present and emerging elders, their law, customs and creation spirits. I recognise that these lands have always been places of teaching and learning, and we're sharing in that today. So as I mentioned, the project that I'm talking about today was developed, or sort of the idea was from the COSA Survivorship Group. They identified it as something they wanted to do and selected me to run it. And this came about because we know that research plays an integral role in providing the evidence to support best practice in healthcare. But there's a lack of funding and resources for cancer survivorship research. So Cancer Australia has done some audits of grant funding, and the graph on the screen shows that cancer control, survivorship and outcomes research does get a significantly smaller share of funding, and that hasn't changed much over time. So because of this lack of resources, it's important to identify gaps in research, conduct current audits of research activity, and then progress, focus research efforts so we can progress the field. And this project also came about based on similar international work, so particularly a pan-Canadian framework for cancer survivorship, which was done in 2017. And there were similar efforts from the US, UK, Europe and Japan, which had sort of developed expert consensus on priorities, but many of which were related to specific healthcare systems, and some also done in specific cancer types. There was a prostate cancer and a testicular cancer research consensus. So the aim of this project was to do a modified Delphi study to determine expert consensus on what the cancer survivorship research priorities should be specifically for Australia. So the study involved scoping of existing international literature to identify potential research priority items, and then was followed by a modified Delphi consensus process. So from the literature scoping, 77 research items were generated, and these included the research priorities, excuse me, and research gaps from the international articles. And the research team grouped these into 5 categories. So 4 of them were research categories, so sort of research topics. And these were survivors' physiological outcomes, survivors' psychosocial outcomes, population groups, and health service topics. And we also created a category for research infrastructure needs. So then a modified Delphi technique was used, which involved a structured process to establish the consensus on these priorities with an invited panel of experts over 2 online survey rounds. So we had 153 experts that were contacted, and we identified these through survivorship-focused research output from the last 5 years, such as presenters at cancer survivorship conferences, chief investigators on NHMRC and Cancer Australia survivorship grants, and first authors on peer-reviewed publications retrieved in PubMed. And alongside the clinical and academic participants, a large number of cancer consumer groups and advocacy organisations, as well as health policy organisations, were contacted and asked to nominate both members of their organisation, as well as cancer survivors and carers who may be willing to participate. to ensure the findings were not biased towards the perspective of particular groups, and the research group didn't have too loud a voice. So of the 153 people we contacted, 82 agreed to participate, and they were sent the 2 rounds of the surveys developed in Qualtrics. So we had 63 experts participate in round 1 of the survey. And in this round, they reviewed each of the 77 initial items that we had provided, and they rated the importance of the item on a Likert scale from 1, not at all important, to 5, very important. And in this round, they were also able to provide comments on the wording and suitability of the items, and also suggest priorities that might have been missed. So analysis of this round 1 data resulted in 1 item being removed, as less than 50% of the sample had rated it as important or very important. And then 16 items were reworded or clarified or combined, and 12 additional items were added. And this left 75 items across the 5 categories for round 2. And the research team in analysing round 1 really tried to make each item sort of comparable to all the other items within its category. So in round 2, we had 68 experts participate. In both rounds, you can see the majority were female participants and academic researchers. And in the second round, participants were asked to select 5 items within each category that were the most important to them and rank them from 1 to 5. And then for those 5 items that they selected, experts were asked to indicate a type of research that might be needed. So for each item, experts could select from etiological or biological research, exploratory research, intervention development, or implementation and dissemination for that item, and they could select multiple types of research. And this was for the 4 research categories, not the infrastructure category. So for example, in the physiological outcomes category, participant might select fatigue as their top priority, and then tick that they thought biological research was needed, as well as intervention development research or something similar. So here are the top 5 priorities for the 4 research categories for the total sample. A bit of a busy slide, but I'll go through it and then go through each category in more detail. But the data was scored so that an item which was ranked as the most important was given a score of 5, and the 5th item ranked was given a score of 1. So each individual item was scored and summed based on all responses, and the final summary score was what was used to create the ranked order and define the top 5. We also created or analysed for average mean scores and the percentage of people who included that item within their top 5. And in terms of the analysis, we did look at the ranked order across 2 different groups, the researchers and health professional participants as one group, and then the others was cancer survivors, advocacy organisations and policymakers. So we wanted to ensure that the research group was not dominating the total sample. And so although there were differences across the 2 groups, it went sort of both ways to drag items up and down. And so we felt that the presenting the results for the total panel ensured that every voice, every person had a say. And in terms of the types of research, you can see these are the majority of participants for each item, and intervention development and implementation was selected by a large majority of participants for a large majority of the items. So I'll go through the categories in more detail. So in the physiological outcomes category, cancer progression or recurrence was the highest ranked, and the majority of experts felt that etiological or biological research was needed. And other high priorities included the management of comorbidities, fatigue and cognitive function, for which intervention development research was selected. And exercise and physical activity, another area where we know a lot of effective interventions have been developed. 75% of participants selected implementation research. Oops. So here you can see, and once again, busy slide, on the left is the whole panel and all the 21 items that were in the physiological category. And then you can also see the 2 groups. So the highest and the lowest ranked items were pretty similar. And while there were some differences, we've kept the total sample as quite consistent. That makes sense. So for the psychosocial outcomes category, fear of recurrence was the highest ranked priority with implementation and dissemination research selected. And I know a lot of PoCoG members have been working in this area, so they would agree that this is a major priority. We've also got distress, anxiety and depression ranked third, and that was for implementation research as well, which was great talks about that yesterday. And other high priorities included economic issues, adaptation and the transition back to daily life, and work and study issues, all of which had intervention development selected by between 76 and 88% of participants. And so here's a list of all the 15 items that were ranked with, again, the total rankings on the left, and pretty similar rankings at the top 5 between the non-research and research groups. But you can see that economic issues was the most important for the consumer advocacy and policymakers, and work issues was a bit lower down. And you can see resilience, positive change and personal growth was brought up much higher in the total sample because of the consumer and advocacy groups ratings. So for population groups, the highest priority was rare cancer types and those underrepresented in research, and exploratory research was selected by 80% of participants. And the remaining important population groups, those with advanced cancer or recurrence, those in rural and regional locations, adult survivors of pediatric cancers, and survivors with low socioeconomic status. And for all of this, intervention development was selected by the majority of participants, but in this case might include tailoring of existing interventions to particular priority population groups. And so here is all the 17 items. Again, on the left, the items ranked for the total panel, and pretty similar top 5s across the 2 groups, but with consumer and advocacy group ranking patients on relatively new treatments as the 5th most important, and those with low socioeconomic status was outside of their top 5. So for the health services category, quality of care research topics were the highest ranked priority, and with implementation and dissemination research selected by 70% of experts, and followed by flexible and equitable models of care, self-management and patient preferences and decision-making, and communication between patients and providers, and patient navigation and health literacy. And again, in this category, there was a big focus on intervention development, or both intervention development and implementation research designs. So here, with the list of all the 13 ranked priorities, you can see that patient navigation and communication items were really made into the top 5 because of the consumer and advocacy group, where it was ranked 2nd and 3rd, while the health professional and researcher group ranked those 6 and 7. And for self-management, it was the other way around, where the academic group ranked it as 2nd and the consumer and advocacy group ranked it at 7th. So it really just shows how the diversity of the panel meant that participants were having a meaningful say, and this wasn't just a sort of academic study that only academics were deciding on the priorities. So the final category identified the most important priorities for infrastructure that will enable high quality survivorship research to be conducted. And the most important of these included data availability, such as access to patient records and data linkage, and then also facilitating and increasing collaboration across jurisdictions and across disciplines, providing funding opportunities, utilising rigorous reporting, and investing in and developing survivorship researchers. So some of these challenges are well recognised in areas of health research generally, but it's important to consider what could be done to improve these issues specifically to progress cancer survivorship research or cancer research generally. And simply identifying these issues may help to prompt opportunities for unifying data sets, and particularly an increased focus on the collection of PROMs and PREMs as well. And investing in and developing researchers is something that can be helped along by the trials groups, and I know COSA's research fellowships really helped do that as well in this area. And for this item, there were only 8 infrastructure priorities, and pretty similar across the 2 groups there. So COSA has developed a 1-page colourful document, which you can see here. I know it's sort of obviously probably a bit hard to read, but you can find it on this website, on the COSA website. So this lists the top 5 priorities for each of the 5 categories. And you can see from the colour coding, items which are blue were the intervention development, and pink, which is implementation and dissemination research, were most prominent, particularly in the psychosocial outcomes category and the health service category. So again, there were many areas there: fear of cancer recurrence, anxiety and depression, self-management, patient navigation, where extensive research has been done on intervention development. And we hope that can focus on translation, dissemination, and transferal to other population groups. So this one pager is available now on the website. We've also got a publication which has been accepted in supportive care in cancer, and that includes the larger tables with all of the items and across the 2 different groups. So when that comes out, hopefully either at the end of this year or next year, I encourage people to read that to find more. So overall, the project used a structured approach to identify important research priorities, and the priorities map onto what we know are unmet needs for cancer survivors. There's also overlap in what was the priorities developed for Australia and what was done internationally, and also in other areas of cancer research in prevention and active treatment. So it's not just the sort of post-treatment survivorship focus. A strength of the study was using the Delphi method. So a lot of the other literature was developed consensus on research priorities through workshops or just expert opinions. So the iterative process we used, as well as the inclusion of the cancer survivors and advocacy groups and diverse sample, really builds the confidence in these findings. And additionally, articulating a type of research needed for an individual item goes beyond what's been done previously, and also really helps people focus their future research efforts, we hope. But I'd also like to touch on a few limitations. So firstly, the priorities that we developed were limited to existing literature. That's how we found the first round. And this was predominantly from Western countries and mainstream populations. So there are obviously differences in research priority topics that are needed for specific populations, differences across diverse cancer types and stages as well. So these priorities are very broad and may not always be applicable to your particular situation. And secondly, I acknowledge that there are a lot of important research topics that could be addressed in cancer survivorship. And we've seen research in cancer survivorship really significantly increase over the last 15 to 20 years in particular, but there's still much work to be done. And during this process, it can be really hard to rank the importance of one over another, and it's obviously very subjective. So while the large number of participants we had and that diversity really helped us feel confident in these priorities, and we've really sort of focused on the top 5. There are a lot of other ones further ranked down. In particular, some of the 6 ranked items, which were very close, were Aboriginal and Torres Strait Islander populations, ranked 6 in population groups, and engagement with consumers and families, ranked 6 as an infrastructure priority. So these are obviously still important, not just focusing on the top 5. But overall, this prioritization can help to focus future research directions. So I hope, and the COSA Survivorship Group hopes, that it can be considered in strategic planning. We really, to provide effective survivorship care, it's crucial that we strengthen the evidence base. So in areas where there's strong evidence of experiencing of symptoms, it's time to really turn to developing interventions and tailoring interventions to different subgroups. And these findings also highlight the potential to adjust research priorities across multiple categories if relevant. So exploring fear of cancer recurrence or distress and anxiety in rarer cancer types, and looking at how care coordination and survivorship care plans can be used to assist in management of comorbidities. Just some examples of how you can use both domains together. So we hope that these priorities can encourage increased collaboration, and they can be used by funding bodies and research groups to help to focus their efforts and improve the quality and impact of cancer survivorship research over the coming years. So thank you for listening. I'd just quickly like to end by thanking COSA and the survivorship group there for supporting this fellowship that allowed me to do the project. And if you've got any questions, I think there's time for that. Thanks so much.
Fantastic. Thanks for that great presentation, Fiona, and brilliant work that will certainly help direct future research and the ideas of people's research. Now, we didn't have any questions come through, so if you do have any questions, then please do let us or put them in the box, and maybe we can follow them up So it's the Q&A box. I should have said that earlier, but we could certainly follow them up towards the end if we've got time.
Lisa,
And the other,
sorry, I have a question.
Go for it.
I have a question. So Fiona, I just really wanted to clarify two things really. First of all, were any of the priorities or around carers and supporting families come up in your Delphi study? It didn't seem to be in the top ranked priorities. And was that because questions around carers wasn't included, and so you were just focusing on patients, or was it that there was no carers in your consumer group? Or
yeah, so great question. There were a few carers in the group, I think only a couple, so obviously not a strong voice. The families and carers as a population group to focus on came up as 11th in the ranked order out of 17. And yeah, I'm not too sure of the answer, but I do think that it was kind of a patient-focused sort of process overall, particularly the first few categories, psychosocial outcomes and physiological outcomes really were focused on the patient. So I think that's something that could definitely be explored in future. Yeah.
And just sort of following on from that, so thinking about patients, did you actually differentiate between, say, adult cancer patients and AYA issues, or was it just focused on predominantly adult cancer patients?
We didn't have any sort of I guess there was no mention of that in the instructions. We did have some pediatric oncologists and AYA consumer groups involved in the survey. But yeah, it was sort of, I guess, up to their own individual interpretation of what population group they were focusing on in answering. And again, in the actual population group section, we did have AYA and survivors of pediatric cancer groups come up. But yeah, the other categories, they weren't specifically adult or childhood either.
Great. I guess there's a few areas for further exploration of priorities then.
Yeah, I think so. This is really like quite broad, and I'd encourage like future work to really do a similar thing in different population groups, because they aren't, as you said, they're not very comparable often. Mm-hmm.
Okay. Thank you. And just in the chat, Sarah has commented that carers of cancer survivorship parents would be good to follow up. So
yeah, definitely.
Fabulous. Thank you for that. Now, I also just wanted to mention that tomorrow we have our brain cancer rehabilitation assessment and interventions for survivorship needs program. So that's 11:30 till 1:30 tomorrow. So if you haven't registered for that and you're interested, then that would be great. It's a great session. There's loads of fabulous presentations there. So don't forget to register for that one tomorrow. So next up, we are very lucky to have Daniel Lindsay and Dr. Daniel Lindsay, I should say, and importantly, this was within the just out of the one of 5 priorities I note. So equally important is his work in cancer survivorship for Aboriginal and Torres Strait Islanders people living with cancer. And Daniel's a research fellow within the School of Public Health at the University of Queensland, with obviously an interest in Aboriginal and Torres Strait Islander people, and also with the in the financial costs of cancer. So I will hand over to you now, Daniel. Thanks very much.
Thanks, Lisa. I appreciate that. And yeah, very interesting presentation, Fiona. Thank you for that as well. So as Lisa said, my name is Daniel Lindsay. So I'm a research fellow within the First Nations Cancer and Wellbeing Research Team within the University of Queensland. So I'm within the team that's led by Gail Garvey, who's just sort of transferred over from Menzies across to UQ. So we are just sort of developing ourselves in that space. And today I'm going to be talking about cancer survivorship for Aboriginal and Torres Strait Islander people living with cancer, and some of the research that we've done in that area. So essentially what I'm going to be talking about, as I said, is just some of the basic research we've done already, and then I'll just talk about what Gail's team's done, as well as some continued research that we are currently running. Again, I'll just quickly acknowledge country and the traditional owners of the land, which I'm on today, the Yagara and Turrbal people, all Indigenous elders, past, present and emerging, and acknowledge any Aboriginal and Torres Strait Islander person who may be listening to this presentation either today or on the recording. So I think there are well-documented disparities in key cancer-related outcomes, including the most important, cancer mortality, between Aboriginal and Torres Strait Islander people and other Australians. So these disparities occur for a variety of reasons, including but not limited to reduced access to key cancer services, lower awareness of effective treatment options, later stage of diagnosis, lower levels of cancer screening, and also mistrust in the healthcare system once they start to interact with it. So unfortunately, each of these factors contribute to different experiences with cancer for Aboriginal and Torres Strait Islander people, their families, and also the wider community. And these experiences differ across the entire cancer continuum, obviously including survivorship as well. So while research suggests an overall increase in cancer survival worldwide, Aboriginal and Torres Strait Islander people continue to report a decline in overall cancer survival rates, which is obviously a huge concern. So despite this, research into cancer survivorship within this population is becoming more widespread as we start to understand why people, or how people can live well with cancer once they've been diagnosed. So as I've said, I'm here today to discuss this research, in particular the research done by Gail's team into survivorship for Aboriginal and Torres Strait Islander people living with cancer. So just some key findings from relevant papers before getting on to Gail's work. So the first of which was a study done by Tam and colleagues in 2018, and about 2017, 2018 was when research started to pick up into survivorship within Aboriginal and Torres Strait Islander people. And essentially, this particular study looked at recruiting First Nations oncology patients, which looked at factors assisting positive cancer experiences. Two major factors stood out, which sort of contributed to both positive cancer experiences. Those were feelings of resilience within the cancer, or the individuals diagnosed with cancer, and also having effective communication, whether that be with family, the larger community, or the healthcare team. And this led to feelings of empowerment and actually being able to have a more positive survivorship experience. So a couple of other studies conducted by Meiklejohn and colleagues have explored areas for improving survivorship experiences for First Nations Australians living with cancer. So again, these are purely qualitative research, and the studies noted some major factors, including having family and community support, creating peer support networks, and having access to cancer-specific health workers, such as Aboriginal liaison officers, and nurse navigators within the healthcare system to basically guide the people through the cancer journey within the healthcare system. So each of these factors contributed to a positive transition from cancer patient to those living with cancer. So finally, a more recent study conducted by Ristevsky and colleagues looked at factors which were critical to assisting the development of a culturally appropriate cancer survivorship model for Aboriginal and Torres Strait Islander people. And again, there were a couple of important factors which were identified within this research. So I think the most important things to note here, and something which will come up throughout this presentation, is the importance of culture. So essentially, culture became the most important factor, needs to be respected, needs to be understood for an Aboriginal and Torres Strait Islander person who is diagnosed with cancer. Putting family first and looking after family, not just the individual patient. Again, that's another pretty clear piece of evidence that runs through a lot of research conducted in cancer within Aboriginal and Torres Strait Islander people. And then we've talked about things like the perception of cancer. So that's generally seen as quite negative, and trying to change that perception and understanding that people do survive cancer, and sharing those stories, I think, is a really important aspect of survivorship within this population as well. And other factors which I'll talk a little bit more about later on in this presentation include access to services and also communication factors, which again are pretty common factors which are raised across all parts of the cancer journey for these particular population. So the optimal care pathways for Aboriginal and Torres Strait Islander people also identify the importance of the survivorship journey. And I'm sure that most people here are familiar with the optimal care pathways. And it is great that we do have one specific for Aboriginal and Torres Strait Islander people. with cancer. So what I thought I would point out is just a few things. And again, I could probably give a whole presentation purely on these pathways. But just a couple of things to note here is that there is obviously a highlighted importance of engaging with healthcare workers of Aboriginal and or Torres Strait Islander background. And I think a lot of emphasis and importance is placed on these particular roles. And also being able to engage, and this is just not the patient who's engaging with these individuals, but also the family, the carers, and the wider community as well. Engaging with health practitioners, primary health care, or liaison officers to support the person throughout their cancer journey. So understanding that the patient's beliefs and definition of living well with cancer. So what does it actually mean to live well with cancer? And I know there's been a lot of research that's done in this area, but unfortunately it's lacking a little bit within the Aboriginal and Torres Strait Islander population. So some of the members of Gail's team, led by Dr. Kate Anderson, are actually currently exploring the issue of wellbeing within the entire population, not just specific to cancer, but we hope to sort of start to adapt that to the cancer space to provide some more understanding about what it actually means to live well, what's important for this particular population. And lastly, I thought it was just another thing which was worth pointing out, which is highlighted within the OCPs. And it's definitely something that in the initial conversations we've had with our key consumers, is that the term survivor is really perhaps not an appropriate term to put onto someone who's living with cancer. And I know that terminology, you can get muddled up in that sort of stuff and lose yourself in that area. But particularly for this population, I think it's something that needs to be considered because of the historical sort of connotations around the term survivor. And a lot of the conversations we've had with our Aboriginal and Torres Strait Islander cancer patients is that they don't see themselves as survivors. So it's definitely of interest to sort of explore that a little bit further and understand what terminology is actually appropriate within this space. So Gail's work really started back in 2015 when there wasn't really an emphasis directly on survivorship, but data was collected on survivorship. And this was done around the creation of the National Aboriginal and Torres Strait Islander Cancer Framework, which Menzies had a huge part of. And I guess in terms of the methodology for this, so through various networks, we recruited key consumers. So again, that's your Aboriginal and Torres Strait Islander people living with cancer, various health professionals, and also researchers in the area to explore the current experiences throughout the cancer continuum. Some of them happen to be focused on cancer survivorship. And essentially what we can see here is just some baseline data collected from about 50 to 40 individuals, with some quantitative results here just highlighting the top 3 issues affecting survivorship and living well with cancer. So barriers to accessing services, lack of appropriate and high quality services across the cancer continuum, particularly in rural and remote areas. So again, that links to a barrier to accessing services. And finally, some social determinants of health, such as poverty, education, housing, racism, etc., which are known to affect the health status of populations. Some qualitative information from this particular study I thought was interesting, and I won't talk through all of these, but I thought it was just worth sharing some of these key quotes that we have here. So they highlight the lack of services that are available for Aboriginal and Torres Strait Islander people. This isn't just, again, a problem with survivorship, but across the whole cancer journey. Lack of cultural connection and understanding of cultural and spiritual healing and well-being for this population and how important that is. And I think this next one is really important as well, because there was a comment, and this is, again, a fairly common comment, that we don't know many people who are actually surviving treatment. So there isn't many stories of cancer survivorship within Aboriginal and Torres Strait Islander people. So we really need to be able to highlight that and talk through the journey of how people are surviving. And it's not just a death sentence. It's something which people can actually have and overcome and have fulfilling lives while they're living with their cancer journey. So just some other qualitative quotes from this as well. Again, I just wanted to share this. A couple of the top ones I think are probably the worthwhile having a look at. The top one in particular, so the concept of survivorship may not be something that has been considered, and it is a white fella term. So survivorship in general, and this ties back in with cancer being a death sentence, is that we don't understand that people can survive cancer, and so how do we overcome that? How do we work around that to make it a more positive experience? And then I think just I'll touch on quickly the relapse, which Fiona pointed out as something that people are concerned about, breast cancer recurrence, or sorry, just cancer recurrence, things like lifestyle issues, and also the huge impact that family has, culture. You can see all the things that I've been mentioning already within these quotes. So this leads us onto a more recent focus that we've come to within Gail's team around survivorship. So when I started with Menzies at the time, but now at UQ, Gail did want to branch out into the survivorship space for Aboriginal and Torres Strait Islanders. And I guess the first thing that we've done in this area in a more recent sense is looking at a national roundtable, which we held in March of 2021, which looked at survivorship for Aboriginal and Torres Strait Islander people with cancer. So this was co-hosted by COSA, and we invited First Nations people living with cancer, researchers and health professionals with expertise in cancer survivorship from across Australia. And so we had a total of 42 participants with 11 key consumers. So those were our 11 Aboriginal and Torres Strait Islanders living with cancer. So within this roundtable, what we aimed to do was discuss what cancer survivorship care means for Aboriginal and Torres Strait Islander people, as well as exploring current survivorship models of care and identifying priorities for improving survivorship care within this population. So to our knowledge, this was the first time major conversations around cancer survivorship for Aboriginal and Torres Strait Islander people with different perspectives, so your healthcare workers, researchers, etc., were actually undertaken within Australia. So we asked three main questions. And so the first question was, what does cancer survivorship mean for Aboriginal and Torres Strait Islander people? And here you can see some of the responses where the colouring, so the red indicates the most common responses, green the second most, and then blue the third most. But you can see here, financial cost comes up again. Again, that was clarified in Fiona's conversation around some concerns with survivorship. Lack of access to services, again, keeps coming up in the research within this population, but also a positive experience of trying to stay strong. So you're staying strong for yourself, you're staying strong for your community, your mob. It's a really important term, and something which was really identified by the cancer patients within the sample that we had. So we also briefly talked about what would a model for Aboriginal and Torres Strait Islander cancer survivorship look like. And I think the sort of end result of the current research that we're doing is sort of in developing a cancer survivorship model. So that's why we have these questions in there. So patient-centered care came out as being the most important aspect. But within patient-centered care, we're not just looking at the patient, we're looking at family, we're looking at community. So sure, patients in the middle, but family and community needs to be strongly tied in with that as well. So the whole cancer pathway should be included, and it should be known that this pathway is not linear. So we're from diagnosis to end of life. And we need to be highlighting preventative care once an individual is diagnosed. So that means it's not just about preventing diagnosis, but also preventing poorer health outcomes once an individual has been diagnosed. And so we've looked at some research already within Gail's team, which is looking at sort of health interventions for individuals who are diagnosed with cancer, to actually make sure that they are living well. So cultural, family, and spiritual aspects must be included as well. And we showed the COSA survivorship model, which is obviously quite text heavy, if you're familiar with that. So our key consumers were much more interested in a more visual format of presenting that model if it was to be produced. So we then finished off the roundtable by asking what were two things that individuals would want to do tomorrow in the cancer survivorship space. And again, these are things which, if you had all the resources, if it didn't need to be a realistic approach, it just needed to be what would you do? And so we looked at some cancer workforce improvements that came up a fair bit. So coordination of care, more nurse navigators within the healthcare system, and that could be an Aboriginal liaison officer, and also cultural and training awareness across the whole cancer continuum for health professionals who are engaging with Aboriginal and Torres Strait Islanders with cancer. I think the most clear thing in terms of probably being able to do as a realistic step is peer support from Aboriginal and Torres Strait Islander people with cancer, so sharing positive survivorship stories, and then some issues around detailed cancer care plans and development of culturally appropriate resources about living well with and beyond cancer, not just for the patient, but for the family, the carers, the communities, etc. So just briefly, the next phase of this study, and I will wrap up very quickly, is that we asked some roundtable participants, so the same group of people that we had in that roundtable, to indicate factors they considered important and achievable in relation to survivorship care for Aboriginal and Torres Strait Islander people. So far we've had 30 respondents, We're currently sort of analysing this data. I just really talk about some prelim stuff here, so I can't cover everything that we've done to this point, but I just wanted to show you some interesting results that we have so far. So in the blue, you can see is the percentage of our First Nations patients who are agreeing that this is important or achievable. And then in the orange, we have the percentage of our non-First Nations participants who are saying it's important or achievable. So on the left-hand side, you can see that we have cancer workforce with First Nations background is highly important, but perhaps when you look at the left-hand side, it's not very achievable. And then also our final two things here is that access to a First Nations cancer nurse navigator, again, very important for First Nations, but not particularly achievable. And also those culturally appropriate resources for community. Again, highly important, but whether they are achievable, a little better, but again, we have some problems with that. And just quickly, just a future, I see you, Lisa, I know that I'm going a little bit over here, but just some future work. We will continue analysing this data in the next rounds of the Delphi study. We have some more roundtable data being analysed by a BH student and looking at that health behaviour interventions, which I've already talked about. So interested in other ideas and collaborations. Thank you very much for your time. I really appreciate it. Thank you.
Okay. Since we haven't got any questions.
Thanks so much for that, Daniel. That was a great presentation. Joe was going to ask a question.
Yes,
Joe, did you want to ask a question?
Yes. Just thinking about from an intervention perspective, do you think based on the work that your team has done, when we're either implementing interventions or developing interventions, is the question that we need to tailor interventions to First Nations people, and have specific interventions, or is it about being more inclusive in the way that we approach people and recruit to research studies, and thinking more broadly, more inclusive in the way that we deliver healthcare?
That's a great question. And I think some of the stuff that I've been involved with around interventions for Aboriginal and Torres Strait Islander people is that it has been very focused on that particular population. So resources designed for that population, and methods of actually being able to interact and so yarning circles as a more appropriate methodology. So I think, yes, it should be tailored for that particular population, but I also think being inclusive on, and I think some stuff's been done around getting more people into clinical trials, Aboriginal people into clinical trials. So I think Gail says if it works for, Aboriginal and Torres Strait Islander people, it's going to work for everyone. So I think it's a matter of, yes, being tailored to that population, but not so much that we are excluding those interventions from being able to be put into a wider audience, because otherwise you're just targeting, obviously it's a smaller population, but you want to be able to say that what can apply to them can also apply to everyone, and making sure it's effective not just to a particular subgroup but to everyone, I think is probably the best way to do it. So I know that's a very roundabout way to answer your question, but I think tailoring interventions to Aboriginal and Torres Strait Islander people is a very strong way to engage with that population and make sure that they are actually getting some impact from them.
Great, thank you. All right.
Wonderful. Thanks again for that great presentation, Daniel. Now we're going to move on. And so next up, we have Professor Janette Vardy, and she is a medical oncologist and clinical researcher at Concord Cancer Centre and the University of Sydney. Her presentation today is on the receiving end, have patient perceptions on side effects of cancer chemotherapy changed since the 20th century? So I'll hand over to you now, Janet.
Thank you very much. It's a great pleasure to present our research on this on behalf of all my co-authors. Sorry, it's suddenly skipped slides. So there were 2 studies that were published called On the Receiving End, and they were really landmark studies published in 1983 and then again in 1993. And the first one, which was conducted by Alan Coates and Martin Tattersall and colleagues, may surprise you, but it was really one of the first ones that looked at what symptoms cancer survivors identified as being the most important symptoms to them, and then ranked the severity. So this first study had 99 patients. They all had advanced cancer and they were all receiving chemotherapy. And they recorded number 1 symptom far and away above everything was vomiting. This was followed by nausea, hair loss, and the thought of coming for treatment. And you can see the other top 10 there. Within the next decade, there was a real change in the antiemetic drugs that were available, and also changes in chemotherapy. So the same group repeated the study a decade later, so it was published a couple of years after that, and this time they had 150 patients. And what you'll see was that there was a shift from concerns about physical to more psychosocial issues. So nausea had dropped to number 5. However, vomiting had dropped to number 5, but nausea was still up there at number 1. But we're starting to see other things affect on friends and family at number 4, and other psychosocial things creeping into the list as we're getting better on top of the physical symptoms. Sorry, this mouse is misbehaving. So we decided it was timely to repeat the study and looking to update the information on patients' perceptions of the side effects of chemotherapy. I'm not even touching it and it's moving. So there's a gremlin in there. And so basically the patient population that we were looking at were people with solid tumour, any stage disease. They had to currently be receiving chemotherapy and have had at least 1 cycle of chemotherapy, have reasonable English to be able to complete the assessment. And the original studies had been done at RPA. We also did it at RPA, but added in Concord, and then later added in Dubbo Base Hospital as well. So we deliberately used the same methodology for the main part of the study for comparative purposes. And what this was a cross-sectional survey, but that was conducted face-to-face, basically as a scripted patient interview, and I'll talk you through that. However, we did add in some additional symptoms, which we constructed with an expert group and then piloted first in 10 patients. So the way it works is the interviewee presents 2 different sets of cards. On the first group of cards, group A, we had listed 1 symptom per card of physical side effects, 69 of them. And in group B, sorry, I'm not touching it, there were 55 non-physical side effects. So patients were shown 1 card at a time, and they were asked to select that card if it had a symptom on it that they had experienced and that they attributed it to their current chemotherapy. Those cards were then taken out, and they were asked to rank them in order of severity. And we then combined the top 5 of the physical symptoms with the top 5 of the non-physical symptoms, and they were asked to select and rank the 5 most severe. And we then scored them to generate an overall ranking. However, we also wanted to look at a few extra questions on our way through. So we also this time asked the patient's medical oncologist and their main chemotherapy nurse to independently rank the 5 symptoms that they believed the patient would rate as their most severe. And then at the end of the interview, we also added in the following patient-reported outcomes. So looking at quality of life, fatigue, anxiety, depression, overall health status, and some extra information on nausea and vomiting. It's obviously got some preset things in it, so sorry, just bear with me as we go back and forward. Our primary aim was to determine the most severe symptoms while people were on chemotherapy. And our secondary aims were to compare their symptoms now with what had been seen in the two earlier studies, to look at associations of symptoms with patient and disease treatment characteristics and patient-reported outcomes, and also to compare their ratings of symptom severity with that rated by the physicians and nurses. So our results. We included 302 patients, and that was 77% of patients approached, and you can see here the main reasons for non-participation. Also the number of oncologists and nurse completed questionnaires. But just to highlight, the study was completed over 2 time periods. So from 2008 to 2013, most of it, and then we had a second burst in 2016. So the median age of our participants was 58, and the median time from diagnosis was 6 months. Just over half were women, and the main sites were colorectal cancer, breast cancer, lung cancer, gynecological cancers. And just over half of the patients had advanced, so stage 4 or metastatic disease. And the current chemotherapy cycle they were on at the time that they did the interview, the median number was 4, but it ranged considerably, and a number of had a number of lines of treatment. So looking at symptom severity, what you will notice is that number 1 now is the effect on my family or partner. And 34% of participants ranked that as amongst their top 5 most severe symptoms, with 12% ranking it as their most severe. The ranking for numbers 2 to 7, nausea, fear of the future, fatigue, knowing what will happen, my life is on hold, and general weakness were ranked by more than 15% among the top 5 most severe symptoms. Here, what we've done is compared symptom severity as rated by the patient, which is on the left-hand column, with that by the staff. And what you'll notice is the ranking of symptom severity for doctors and nurses actually matched pretty closely that of the patient's own rankings. So 6 out of 10 of the symptoms ranked most severe by patients was also ranked by doctors and nurses among the 10 most severe. We looked at the quality of life, and we found that the severity of several of the non-physical symptoms was associated with poorer overall quality of life as measured by the FACT-G, and also with increased anxiety and depression as measured by the GHQ-12. So in general, the other PROMs reflected fairly well what the patient had reported as their symptoms using the card sort. Comparing changes in symptom severity from 1983 and 1993, you'll notice that vomiting, which was number 1 in 83, had dropped to 5th in 93, was now rated, and here we only use patients with advanced disease because that's what the 83 study had, was now 23rd in order of severity. Nausea had been second, then first, and dropped to 5th place in our study. And concerns about effects on family went from 10th to 1st. So our take-home messages is that clearly effect on family or partner was rated as the most severe, with issues such as fear of the future, not knowing what will happen, putting my life on hold, still being major issues. And we need to acknowledge that nausea, fatigue, and general weakness still remain very common concerns. We were pleased to see that the perceptions of the oncologists and the cancer nurses in rating the top 5 was fairly consistent with what the patient self-reported. Finally, our team would like to dedicate this study to Martin Tattersall and Rhonda Devine, who both through their work were able to improve the lives of people living with cancer, and both were involved in this study. Thank you very much for your time, and I'm happy to answer any questions.
Thanks very much for that great presentation, Janet. I really liked the card sort methodology. I thought that was great. What I was wondering whether you, when you did the analysis, whether you did any control around number of treatments, so that you could identify whether there was a change in priority for people, for example, that had only had one treatment versus people that are up to their 7th or 8th.
No, we did look at that very briefly, but we didn't look. There was too much variety of that. We could probably do it by grouping it. We did look at it by men, women, by different chemotherapy types, by different tumour types, but not based on, because there's both the number of lines of treatment they've had and then the number of cycles. So it actually becomes a bit tricky.
Fair enough. And I think great research nonetheless. Now, we do have a question that's just come through. So Tim is asking, I wonder whether participants commented that fear of the future and not knowing what will happen, and to a lesser extent putting my life on hold, are very similar. So I guess that suggesting that they are similar in their comments. So if they were combined, whether they'd come out on top, I think. So
yeah, it's a good question. We were hamstrung, if you like, for obvious reasons, with sticking to the exact wording of the original symptoms and using that methodology. However, we did add in some of those extra ones ourselves, with like fear of the future. We acknowledge that there is similarity between some of those, and we haven't grouped them together.
Fantastic. All right, so let's move on because we are already a little bit behind time. So next we've got Dr. Cindy Tan, and Cindy's going to be talking to us about her presentation, which is Do Specialists Use Survivorship Care Plans, a qualitative analysis. So Cindy was awarded her PhD from the University of Sydney in 2013. And she's currently working at the Concord Cancer Centre and Sydney Cancer Survivorship Centre at Concord Hospital. So welcome, Sydney, and I'll let you, Cindy, and I'll let you take it away.
Thank you. On behalf of my co-authors, I would like to thank you for giving us to present our work. So, okay, yeah. Survivorship care plans summarize survivors' cancer diagnosis and treatment summary. It includes survivors' reported symptoms, side effects, and their needs. So, and that same document also including a follow-up plan to address these needs. Sydney Cancer Survivorship Centres implemented the use of a structured care plan at inception in 2013. The care plan was prepared before the survivors came to our first clinic. At the time of this initial clinic, the content of the care plan was discussed and confirmed with the survivors. And after completions of the clinic, the recommendations from the multidisciplinary team were added to the care plan. A copy of the care plan was then sent to cancer survivor, their GP, and the cancer specialist involved in their care. This care plan actually takes a lot of consultants' time to prepare. So we actually are interested to know if the care plan has been utilized by our stakeholders. So we have conducted an evaluations of the care plans in patients attending the Sydney Cancer Centre clinic, but not quite know whether our cancer specialists and GPs actually, if they use and what's their view on this care plan. So the study aims to explore their use and perceptions of the care plan in the follow-up cancer care. So currently we're still collecting data from the GPs, and today will be focused on the findings we obtained from our cancer specialists. We used a sample of convenience. So basically we invited the cancer specialists like the medical oncologists, radiation oncologists, and surgeons who have referred the patients to our clinic to participate in the study. We used the interview guides as displayed in the table here in our semi-structured interview. So the interviews were conducted either face-to-face or through phone. And it was audio recorded and transcribed. Content analysis was performed to identify the recurrent themes. Two researchers were initially coded the data and then discussed in the group. There were 4 of us. Any conflicts were resolved through the discussions. We managed to interview 15 cancer specialists. Unfortunately, one of them had to be discarded due to the poor audio quality. So the demographics from our participants were, 9 of them were medical oncologists, 1 with a radiation oncologist, and 4 were surgeons. The median age group was 43. 9 interviewees were female. Most of them reported work experience as less than 20 years as cancer specialists. 8 themes were identified: awareness of the care plan, how to access it, the value and the use of the care plan, the content, format or layout of the care plan, the process, the systematic issues and recommendations on how to improve the care plan. In terms of the awareness, majority of our participants were aware of the care plans, but 5 of them were not aware that they can actually access these care plans on our electronic medical systems. Those who were aware of the care plans actually wouldn't find it not easy to locate the care plan on the EMR. Most of our participants believe the care plans are available for GPs and patients, but for the cancer specialists themselves, the main value was really the allied health inputs in the care plan. In terms of the use of the care plan, for cancer specialists was limited and varied. So most of them perceived the care plan was useful for cancer survivors and their GP, but not quite for themselves. But if they were to use it though, the care plan was used to flag the symptoms, initiates referrals, or as a reference guide. When we talk about content and format, majority of them were thinking the content of the care plan was thorough and concise. Contrary, some thought it was too detailed. Some of them felt that the standard layouts are problematic, and some things that the volume of information in the care plan make it difficult to work out what is important for GPs. there were issues identified in terms of the process, and currently the access and distributions of the care plan could be improved. There were perceptions of the need for clearer role differentiations and expansions of the role of GPs. When it comes to recommendations, most of the participants think that the more stakeholders input is recommended, especially the GPs, basically asking what GP wants in the care plan, and that's what we are currently doing. Tailored informations. This care plan was sent to 3 stakeholders, and obviously different patients and consultants and the GPs actually do have different requirements and level of literacy. So it was recommended to improve the readability and access to the care plan, and to ensure the care plan is maintained, keep it up to date, and to look at strategies to highlight important informations and streamline the presentations. In conclusions, they think that care plans are available with benefits to use a more structured format, and specific name file in the electronic medical records to improve accessibility and usability would be ideal. We would like to thank all the participants who have taken part in the interview, and also the funding support from Concord Cancer Centre. Thank you.
Fantastic, and that sounds like great work, Cindy. I'm wondering whether you have any plans to now do a quantitative assessment using the information that you gained from that research.
Sorry, can I clarify, when you say quantitative research, is more all aspects of things?
So when I say quantitative, so you've done interviews with the
cancer specialists,
clinicians, and so I'm wondering whether you'll do sort of develop that into a survey and do it sort of more broadly, so that you've got a broader group of participants that will be able to feed back.
All right. Yep.
Yep.
I guess this work was initiated because that there's a lot of efforts being put through to develop the care plans, and every clinicians do prepare the care plans if they do use it differently. So the information actually obtained from here is really wanting to get an idea. And yes, you're right, and we can certainly thinking for a broader groups in terms of other cancer specialists, what's their view and things. One of the key findings here, though, they actually do value it and see the importance of it, but they themselves actually don't see it, don't use it. So in that case, I'm not too sure whether that would change for a broader group as well. I think the really key target group for us, one is the GPs that we really want to get the input. Unfortunately, we haven't finished the study yet, so we couldn't present the data here, and also really try to engage our survivors again to see how they use the care plan and how we can improve that communications between the teams.
Fantastic, and I'll look forward to watching your further work on that as it unfolds. Yeah, that's great. All right, so we will continue on, and so now we've got Dr. Erin Pitt, and she's presenting on behalf of Natalie Bradford, who was who needed to take leave urgently. So thank you, Erin, for stepping in for your colleague. And so Erin is a research fellow with Cancer and Palliative Care Outcomes at the Centre of Health Care Transformation at Queensland University of Technology. So I'll hand over to you, Erin, and if you'd like to share your slides. Erin, are you muted? Just let me have a bit of a look. Yeah, look muted. Okay, so what we might do, it looks like Erin's having some technical issues there. So what we might do is move forward. If Chloe, will I be throwing you completely on the spot if I ask you to present while Erin looks at what she might be able to do, and we'll come back to Erin. Does that sound okay?
I'm totally fine with doing that.
Wonderful. Thanks so much for that. So in that case, we've got Chloe Lim here now, and she's going to be presenting survivorship experiences of people with advanced colorectal cancer, and it's a mixed method study. And Chloe's in the final year of her PhD candidature with the Centre for Medical Psychology and Evidence-Based Decision Making at the School of Psychology at the University of Sydney. So thanks so much, Chloe, and take it away.
So thanks everyone for having me. Just before I begin, I just wanted to thank my supervisors, Professor Phyllis Buteau, Dr. Rebecca Laidser-Powell, and Professor Jane Young, and also just acknowledge the funding that I received through my scholarships. So in terms of colorectal cancer, this is the third most common cancer worldwide. Of the people who get diagnosed with colorectal cancer, approximately 18% of these people get diagnosed with stage 4. And of the people who get treatment with curative intent, approximately 30 to 40% of these people eventually develop a recurrence. However, we do nowadays have improving treatments which enable people to survive with advanced colorectal cancer and also survive for longer periods of time. So some of these treatments, which I'll just go over very briefly just for the sake of time, but these include liver resection, and that involves surgery when the cancer has spread to the liver, CRS-HIPEC, which involves surgery and chemotherapy when the cancer has spread to the peritoneum, otherwise known as the lining of the abdominal cavity. And we also have pelvic exenteration, which is quite a radical and extensive surgery. And that's when the cancer is spread to other organs in the pelvic region. It might involve the removal of several organs and might also involve the addition of stoma bags, which are bags that are externally attached to the body to collect waste matter like urine and feces. And so these are just some examples of surgical treatments for advanced colorectal cancer. If someone is ineligible for surgery because maybe the cancer has spread too far, that's when palliative chemotherapy comes in. And while it is palliative, it can actually increase life expectancy, and it can also improve quality of life as well. So these are just some examples of treatment for advanced colorectal cancer. Currently, there hasn't been too much research in terms of what the survivorship experiences are of people who undergo these treatments. And that's where this study comes in. So basically, that's what I wanted to look into. And just as a side note, I also wanted to see whether experiences of survivorship differ depending on the different treatment procedures that people have. So to do this study, I recruited via clinicians from Concord Hospital and Royal Prince Alfred Hospital. The inclusion criteria were Australian adult residents who had received one of the treatments that I previously mentioned, and they were 6 months to 2 years post-surgery or post-diagnosis. I conducted semi-structured qualitative telephone interviews with participants. These included the topics such as life since treatment or diagnosis, employment, supportive care, and social functioning. And these interviews were analysed through a framework analysis approach. I also administered some quantitative questionnaires, and this was just to characterize the sample and also inform the qualitative analysis. And this data included demographics, cancer information, quality of life as assessed through the FACT-C and a distress thermometer, as well as a score for financial toxicity and well-being. So just going to briefly skim over the demographic results for the sake of time, but eventually I recruited 38 participants. About 42% of these were male. The median age was 59, and participants were had a median 14 months since treatment. In terms of the quantitative scores, again, just going to go over this briefly, but they had pretty similar results across treatment groups. And this was a small sample size, and this data was just to sort of characterize the sample. So I really did just want to spend more time on the qualitative themes. So we found 6 overarching themes, and I'll just go through them one by one. So the first is that having advanced colorectal cancer, it can be a very overwhelming experience that can impact many domains of someone's life. And you can see that in this quote here. This person says, I went from being someone who was running their own business successfully and being married and active in my environment and community to pretty much becoming a recluse. I had to sell my business because I was no longer able to run it. Now, a lot of the things that I like doing, I can't do anymore. And my wife left me because she didn't want to become my nurse. So you can see how having advanced colorectal cancer has really impacted this person's life. On top of that, you also have a lot of compounding and interacting effects, because a lot of these people are having multiple treatments being done, multiple side effects that they have to manage, and multiple organs that were also treated. So one example is this person who during chemotherapy had to take nausea medication, and they say for some reason that medication always blocked their stoma, and they had to manage that stoma blockage while also being in pain from their pelvic exenteration operation as well. The next theme is just that having advanced colorectal cancer, as opposed to maybe early stage cancer, this experience can be quite a long haul, and this experience can be very unpredictable, bumpy, and wearing. So this pelvic exenteration survivor says that their experience with cancer has been going on since 2015. She's got 2 young kids that have had to see her go through everything. She wants life to return to normal so that the kids don't have to see mum being sick all the time. So obviously with these impacts, this can really affect people who are working. It can affect their ability to continue work or return to work, and this can obviously have financial implications. So on the left here, this person is still on chemotherapy medication, and that's causing some side effects that are interrupting their ability to do their job, which is a manual labor job. So this person says, my goal is to go back to work, but I don't know what I'm going to do, and what aspect of work I'm going to do, I don't know. I might not be able to return to work full stop, because it looks like I'm going to be on this medication for the rest of my life. So I'm nervous, I've got a young family, a mortgage, it's stressful, and you just don't know. So there's a lot of uncertainty for this person here. However, if people were able to return to work, it was actually quite beneficial for their mental health, for their social well-being, and their recovery as well. So on the right-hand side here, this person says, work was a bit of a savior. My co-workers and my clients, it helped me a lot. I would recommend working if you can. Then we've also got this theme about people's experiences with the healthcare system, and just that confusion about who is actually responsible for managing survivorship issues. So on the left here, this person says that they think there's a gap between the GP and the oncologist. The GP sends you off to your oncologist. I think that they think your oncologist is just going to take care of whatever comes up, whereas I think the oncologist is going to take care of your cancer, but not necessarily the side effects. Who's going to monitor the side effects? Whose responsibility is that? And on the right-hand side here, this person is really wanting more support mentally in terms of mental health. But they say, you know, that's probably not part of their job as well. I don't know if I'm asking too much. So again, that confusion of whether it is actually the doctor's job to be managing those survivorship challenges. And just to end on a happier note, we also found that a lot of these people used a lot of coping mechanisms to try and cope with these negative challenges. And a lot of this was about taking back control. So I won't read out the whole quotes here, but this person says they lost so much control of their life. So that is a coping mechanism, taking back control. And this person says that one form of taking back control is choosing who they want to tell that they had cancer. And this last person says, I'm not going to change my life for cancer. I'm going to integrate it into my life rather than having my life turned upside down because of cancer. So basically, we found that treatment for advanced colorectal cancer can have a lot of impacts on survivors, including the inability to return to work, which in turn can have really distressing consequences as well. So we need some educational resources to help the larger community help to integrate that transition. And for people who really are unable to return to work, we need to help them derive meaning from other aspects of their lives. And this is where meaning-based psychological interventions have been shown to be quite promising for that. On top of that, we also need support from allied health in terms of identifying and managing physical and psychosocial challenges. And this is where we really need routine screenings throughout follow-up to make sure that any problems are being identified. But we do know that healthcare professionals are sometimes hesitant to do these screenings because they don't know if they can manage any challenges that come up. And that's where education and training needs to be done to ensure that these healthcare professionals do have the confidence to do that. And lastly, we just need support from large consumer colorectal cancer organizations as well. And they can help in the dissemination of information and education, not just to the patient and their carers and family members, but also to employers, colleagues, workers' unions, as well as the larger community and healthcare professionals as well. That's my presentation. Thank you so much.
Thanks for such a great presentation. And I think that, I really resonated with the idea of people on a long healthcare journey not knowing who to go to for particular symptoms. And so it sounds like you've found that yourself. That was great. Jo, you mentioned that you had a question.
I do have a question. I just wanted to ask Chloe, given that pelvic exenteration is such radical surgery and it's different in scope to something like, say, a liver resection or colorectal surgery where there's a stoma, did you see any qualitative differences in, say, those that were receiving palliative chemotherapy or who had sort of a more standard colorectal surgery? Compared to the pelvic exenteration patients, given the scope of typical pelvic exent surgery?
Yeah, so we actually did find that, I didn't have enough time to talk about this in the presentation, but most of the treatment groups actually were relatively similar, but pelvic exenteration survivors were people who tended to feel a bit more helpless in terms of their recovery, like maybe they had more physical functioning limitations, they had to manage their stoma, they were weaker, and so maybe they had to rely on their family and friends and carers, and so they did have a lot of feelings of helplessness, and they also had issues in the long term, so recovery was a lot longer than they expected, and they still hadn't quite fully returned to normal, as opposed to the other treatment groups where over time they either returned to normal or they kind of accepted that this was their new normal and they were kind of fine with it. The pelvic exenteration group tended to be struggling a bit more in the long-term recovery. Oh, just on mute.
All right, fantastic. Thank you for that. That's great. So we've just got a comment in chat. Great presentation, Chloe. Did you capture any data, supportive care services that these advanced cancer survivors found useful, e.g. cancer nurse coordinator, support groups, etc.?
I did ask about, so the main aim of this study was to talk about survivorship outside of the healthcare system, but healthcare data kind of just cropped up. But some people did say that the nurses were really helpful. People with stoma found that the stoma nurses were really helpful. But they didn't, I think most of the people that I talked to were really against support groups for some reason. And I think that related to, they didn't want to kind of dwell on this period of their life. They kind of wanted to get over it and just sort of move on with their lives and not talk about it anymore. But yeah, I'm not too sure if anyone really mentioned the cancer nurse coordinators.
Okay, great. Well, thank you very much. Great presentation. So we might just try to get back to you, Erin, see how you go. All right, this is looking more successful. Now, have you got, if you just unmute yourself, Erin.
There we go. Okay, how's that?
Perfect. All right.
Good. I apologise very much.
That's okay. Take it away.
Okay, lovely. No need for another introduction. I'd just like to acknowledge that I'm presenting on behalf of Associate Professor Natalie Bradford, but I've been involved in this work as well. It's really around late effects for survivors of childhood cancer. And this afternoon, I'm going to be presenting some results from a study that where we were particularly interested in the relationship between symptom burden, quality of life, and self-efficacy in the AYA population. Okay, so we know that there have been many advances in cancer treatment and supportive care, and this has really contributed to huge improvements in survival rates over the past up to 60 years, where approximately 87% of children who are diagnosed with cancer can expect to survive. However, we are seeing high levels of morbidity by this population group. They experience many comorbidities for many years after their treatment. And so by the age of 40, 4 out of every 5 experience serious late effects. So it's imperative that we do intervene to improve these long-term health outcomes. I've put this picture in here because we could say that the slope of this mountain correlates with the slope of improvement in survival for children and adolescents with cancer. But as we see further down the mountain, some people may be left behind, and we need to do what we can to make sure everyone gets the opportunity to reach their goals in life. A very complicated diagram that you may be familiar with. This busy slide just highlights the many areas of late effects across many organs and systems, and thus we have a pronounced and significant, there are many pronounced areas for improvement in terms of child and adolescent long-term effects and survivorship improvement. So the research I'm presenting on this morning, we aim to investigate the potentially modifiable factors as targets to improve outcomes for childhood cancer survivors. So this was some research that was undertaken at the Queensland Children's Hospital in Brisbane, and it was a cross-sectional design with a very small cohort of about 30 participants. Sorry, not of about, there were 30 participants. So some of the data collection measures that we used, we collected information on symptoms using the Pro-CTCAE questionnaire. We looked at quality of life using FACT-G, health self-efficacy using PROMIS, and particularly for managing health conditions, as well as other self-reported health behaviours, exercise, diet, etc. Participants wore a Garmin activity tracker to monitor sleep, daily steps and activities, and diet was collected using self-reported diary. With our analysis, in terms of the symptom variables, we grouped the categories into 3 categories: none, mild, and moderate to very severe as a category in itself. And we undertook bivariate linear regression to explore the relationships between symptoms, health self-efficacy, and quality of life. And then we adjusted these models for age and sex. So we did approach 43 people, and 30 enrolled and completed the study. We can see some common reasons for declining to participate were being too busy, but it was also quite appealing for people to participate after so much treatment, tests and investigation. It was just another burden almost to consider participating in research. So in terms of symptoms, there was an average of 9 symptoms persistently experienced at a moderate or higher intensity. And some of those main symptoms experienced in quite high severity were fatigue, problems with memory, concentration, joint pain, irregular menstrual periods for females. Quality of life, overall, they scored lower, our sample scored lower than the Queensland population norms for data collected using FACT-G. And also, the FACT-G has several different subscales, and we found that compared to the Queensland population norms, our sample particularly scored lower on subscales of physical wellbeing and emotional wellbeing, but higher on social and functional wellbeing. And with health self-efficacy, 2/3 felt that they were confident in their ability to self-manage their health and their symptoms. So I guess the 2 main things I wanted to highlight here, if we look over here in terms of the demographics, some of the demographics we looked at included time since treatment was finished, and a lot of people have finished treatment quite a long time ago. So these are really, not only are these symptoms being experienced in quite high severity, but we have people who have finished treatment more than 5 years ago, 5 to 10, 10 to 14, more than 15 years ago. And so these symptoms are both still persistent, and our quality of life, the quality of life of our sample is much lower than population norms. So with our demographics being particularly interested in our age at diagnosis, the time since treatment finished, and sex, the demographics were not associated with our outcomes of symptom burden, health-related quality of life, or self-efficacy. There was no relationship between our demographics and our variables of interest. And we can't change these. Obviously, our demographics, we can't change those. But we can see here that our symptom burden is correlated with our health-related quality of life and our health self-efficacy. So what can we change here? What can we potentially target and change? In terms of our symptom burden, we found that a higher related quality of life was associated with a reduced symptom burden. That's the top line here, minus 0.91, and that was statistically significant. We can also see that a higher symptom burden was associated with a lower health self-efficacy. In terms of our health self-efficacy, a higher health self-efficacy was related to a higher level of quality of life. And so, in terms of our quality of life, higher quality of life related to lower symptom burden, but it wasn't reciprocally related to health self-efficacy. This is a slide showing the questions that were asked in terms of health self-efficacy. And so this gives an overview of the 20 items that were asked as part of the PROMISE questionnaire. And this shows the proportion of people from not at all confident through to very confident in terms of how these questions were rated by our sample. We can see here some that are of particular concern, and they distinctly relate to symptoms. So there was a fair proportion of people who were somewhat confident, a little confident, or not at all confident with their ability to keep symptoms from interfering with recreational activities, making decisions about their own health, and if they are experiencing symptoms, being able to manage them. So if we focus on areas that young people were less confident, we can see that symptoms and symptom management is really a feature in the responses to these questions. So it seems, so from the findings of our research, we believe that more research is required really to confirm our findings in young cancer survivors and to develop interventions to address the issue of persistent symptom burden. So We also need to understand the effects of treatment on not only symptoms and persistent burden, but also long-term psychosocial health outcomes. It goes beyond those physical symptoms that are experienced at treatment and beyond treatment, but to the long-term psychosocial impacts. This research may help us to recognise the gaps in service delivery. So, for example, there could be a greater need and emphasis on catering for health self-efficacy, and we may enable improvements in other health domains, including symptom burden and quality of life, by focusing on health self-efficacy. And of course, we need to identify, understand, and address the barriers to interventions to ultimately enable us to implement changes in practice. So in summary, health self-efficacy is a potential target for interventions for long-term survivorship. We recognise that optimising symptom management is continually an extremely important aspect of cancer survivorship. And some of our future research is going to focus on investigating the correlations with other health behaviours, including physical activity, diet, and sleep patterns as an extension to this work. Thank you.
Wonderful, and thanks for that great presentation and for stepping in late to help your colleague Natalie out. So that's wonderful. Now, I actually had a question around, I think that that's a really important point that you make about assisting with development of self-efficacy. And I guess I wondered whether you knew of a timing or whether there'd been any research around timing of when that would occur in conjunction with treatment for cancer, or in the recovery period, or in fact at a later period.
I must admit, no, we haven't looked at that. Certainly, timing of intervening around self-efficacy could be incredibly important. And in my opinion, certainly I think it should be occurring during treatment. But as you say, that the needs could be different at different stages of survivorship, and that would be absolutely an interesting area to explore. I might make a note of that. Thank you.
All right, fantastic. So thank you. All right, so let's move on. So next up, we have Courtney Subramaniam, and I hope I pronounced that right, Courtney. She's a PhD candidate in the Cancer Treatment Toxicities Group at the University of Adelaide. And she's going to be presenting today on 5 FU induces acute neurodegeneration, followed by persistent neuroinflammation. Oh goodness, I'm just really messing this one up, aren't I? Inflammation, a new mechanistic hypothesis for neurological complications of cancer therapy. And Courtney, huge apologies for just really messing that entire intro up.
No worries.
But I'll hand it over to you now.
Thank you, Lisa. It's a bit of a wordy title I have, but basically today I'm going to be telling you a bit about my preclinical research looking into acute neurodegeneration and persistent neuroinflammation as key mechanistic factors underlying the development of chemotherapy-related neurotoxicity. So while there are many varying neurological side effects associated with chemotherapy treatment, such as depression, anxiety, fear of recurrence, and sleep disturbances, probably the most well-defined side effect, mechanistically speaking, is chemotherapy-induced cognitive impairment, with symptoms affecting memory, executive function, learning, concentration, and processing speeds. To put into perspective the impact of these side effects on the population as a whole, there are 2 times the number of individuals living with or beyond cancer experiencing cognitive impairment compared to those with Alzheimer's disease. And because these symptoms can persist from anywhere between 6 months and up to 20 years post-treatment, chemotherapy-induced cognitive impairment causes significant psychosocial stress and ultimately limits employment prospects for cancer survivors severely impacting quality of life. Despite this, it remains unclear how systemically administered chemotherapy agents are able to drive the central neurotoxicity that underlies the development of chemotherapy-induced cognitive impairment. Over the past 10 years, a huge research effort has been placed on identifying the neuropathological events occurring within the CNS following chemotherapy treatment that may underlie the development of neurocognitive symptoms. Specifically, preclinical studies have established that chemotherapy treatment causes an increase to the levels of pro-inflammatory markers, such as cytokines and MMPs present within peripheral circulation. Chemotherapy treatment has also been associated with damage to blood-brain barrier integrity, as well as activation of both microglia and astrocytes in neuroinflammatory processes. Furthermore, it is well recognized that the exposure of neurons to both chemotherapy agents and these pro-inflammatory factors in vitro can cause neuronal damage that ultimately leads to neurodegeneration. However, because these findings have been established through studies which were largely cross-sectional in design and generally focused on one of those mentioned outcome measures in isolation to the rest, the exact timeline of mechanistic events occurring from the acute to subacute and then finally chronic setting following chemotherapy still remains relatively unclear. As such, I aimed to develop a model of chemotherapy-induced neuroinflammation and characterize the acute and chronic changes to neuronal proliferation and glial cell function following chemotherapy. I therefore hypothesized that chemotherapy treatment will induce neuronal damage, which precedes chronic neuroinflammation. So to address this hypothesis, I treated 24 female mice with a single bolus dose of 5-FU and humanely killed an N of 3 mice at each of the time points outlined in Figure 1, which were chosen to reflect the acute, subacute, and chronic setting following treatment. Neurogenesis, which was assessed through immunofluorescent staining of double cortin, was used as an indicator of potential direct cytotoxic injury because given 5-FU's mechanism of action, neuronal proliferation would likely be affected if the agent was able to enter the CNS. Neuroinflammation was assessed through immunofluorescent staining of IBA1 and GFAP, markers of microglia and astrocytes respectively. And finally, real-time PCR was used to assess the expression of key genes of interest. All immunofluorescent images were analysed using the ImageJ software, and the percent area stain was found. And then delta CT values were calculated for all genes of interest relative to the housekeeper gene beta-actin. Statistical comparisons were performed using a one-way ANOVA, and then a Pearson's correlation coefficient was used to determine any statistically significant associations between these outcome measures. So moving on to results, first of all, I found that 5-FU decreased the levels of neurogenesis seen in the acute, subacute, and chronic setting compared to day one controls. And this was observed through a significant reduction in double cortin staining, which is shown in the representative images as the red cells. And the fact that such a significant drop was seen at such an early time point, so only 1 day post-treatment, it's suggestive that the injury is likely occurring or possibly occurring due to direct cytotoxicity of 5-FU, because it is unlikely that secondary mechanisms where peripheral markers enter the CNS to initiate neuroinflammation and then induce neuronal damage have enough time to occur in that 24-hour period post-treatment. I also found the expression of double cortin shared a positive correlation with the expression of B-cell lymphoma 2 or BCL2 following 5-FU treatment, which is shown in Figure C. Given that BCL2 is known to enhance neurogenesis and inhibit apoptosis, it is possible that the decrease in BCL2's pro-neurogenic and anti-apoptotic effects may underlie the decrease in neurogenesis seen following 5-FU treatment. So moving on to neuroinflammation results or related results, I found that 5-FU induced acute microglial activation, which was seen through increases in IBA1 staining, which appears in the green in these representative images. And this was increased significantly within the dentate gyrus and CA3 regions of the hippocampus, as well as the prefrontal cortex. Interestingly, these brain regions are all intrinsically linked to cognitive function, with the hippocampus largely responsible for memory function and the prefrontal cortex involved in executive function. A general trend was observed across all brain regions, with the highest levels of microglial activation seen at acute time points, and then these levels of activation generally returning to baseline by chronic time points. In contrast to this, 5-FU induced global astrocyte activation across the multiple brain regions shown in this diagrammatic representation, but this was primarily seen at chronic time points. And sorry, I didn't mention before, this was shown through increased GFAP staining, which is represented as the red cells in these lower images here compared to controls in the above images. I also found that the expression of GFAP, indicative of astrocyte activation, within the hypothalamus shared a positive correlation with the expression of the interleukin-6 receptor, which is commonly seen to increase during a sustained neuroinflammatory response. And as shown in Figure A, the expression of interleukin-6 receptor was also significantly increased at chronic time points compared to controls. In summary, I have shown for the first time that decreased neurogenesis along with BCL2 expression accompanies microglial activation within 24 hours following 5-FU treatment. This positions acute neuronal damage and microglia as the initiating factors for downstream neuroinflammation. However, because both of these events were seen during that early acute setting, we are unable to attribute all causality to either of these neuropathologies as the true initiating event, as both of these have been shown to influence the other in previous research. What can be concluded, however, is that the activation of microglia precedes the activation of astrocytes, suggesting that the acute microglial-derived neuroinflammatory response to 5-FU treatment induces the chronic activation of astrocytes, which potentially through the action of the interleukin-6 receptor may drive the persistent neuroinflammation seen following chemotherapy treatment. And overall, this study was a very early study to define those neuropathological events occurring within the brain. And I'm now going on to see whether I can alter these events through therapeutic intervention targeting the microbiome. Thank you very much for listening, and thank you for having me.
Thanks so much for that, Courtney. And it was just such an interesting presentation, despite it being in its early stages, certainly from the perspective of the person who is experiencing cognitive difficulties. It's such a distressing area for them. So this preclinical work is critical. So really well done there. Jo, did you have any questions for Courtney? Oh, okay, we've got a question from Janette.
Yeah, Courtney, really nice work. I was just wondering whether one of the ways that you could sort out how much of it is occurring in that acute period and what it's due to is it worth looking at doing the assessments rather than at 24 hours, but doing some earlier time frames for that?
Yeah, absolutely. So we initially planned the study thinking that nothing would happen that early.
Yeah.
And that's why we chose 24 hours as that first time point. But it's definitely something we're thinking about, getting a few more animals to look at 6 hours post-treatment, just to see what's that first thing that happens.
Yeah, that would be very interesting.
Yeah.
Thanks.
And Claire has popped a question in chat, and as a psychologist, I'm absolutely interested in this one myself. So she says, really informative. In terms of application of your findings, do you see this research as eventually being able to broadly inform, assist psychologists working with patients who are experiencing chemotherapy-induced cognitive impairment?
Well, yeah, it's very early stages at the moment and very preclinical at the moment. But I guess my next step is to look at how microbiome-related interventions then affect the levels of neuroinflammation and those decreases to neurogenesis, to kind of determine whether there is a microbiome element to these neurological side effects of chemotherapy, because that has been found to contribute to gastrointestinal side effects of chemotherapy. So I guess the end goal is to see whether certain interventions like probiotics or prebiotics could be beneficial in these individuals who are experiencing cognitive impairment or other neurological side effects of cancer treatment.
Fantastic, and I think that's a great way to go, and certainly one that I guess from a person looking at your research now can see the way that could be translated into people that are experiencing these side effects. So very much look forward to your research as it unfolds and hearing more about it. So now we're about to change pace a little bit, and we've got a couple of presentations coming up on measurement. And so the first one is by Conjoint Associate Professor Kerry Clover, who is Conjoint Associate Professor of Psycho-oncology Service at the School of Medicine, Public Health, College of Health, Medicine and Wellbeing, and her presentation is Convergent and Criterion Validity of Promise Depression and Anxiety Measures relative to Legacy Measures and Structured Diagnostic Interview in cancer patients. And it's actually a really nice segue from Courtney's, because we are still in that space of depression and anxiety, but we're now certainly moving to the patient and rather than the preclinical. So please take it away, Kerry.
Thank you, Lisa. All right, let me just get onto my slide view. So can you hear me okay?
Yes, that's
yes,
fine.
Okay, and does the slide look all right?
Now, I can't see a slide.
Oh, that's because I didn't press share, sorry. Oh dear. I shouldn't admit that on national conference, should I? It's like, oh, it's my internet. Okay.
Okay, still can't see a slide.
Here it comes. Slowly, hopefully. Come on. All right, how is that?
No, still no slide at this end.
What? All right.
Kerry, if you've got two screens, sometimes it the second screen interferes with.
Okay, I'll turn that second one off. Let's see what happens there. All right, Zoom. Share So share this one. All right.
That's
Okay.
the way. All right. I'll
All right.
leave it to you.
Okay, so we'll go to slideshow. How's that looking?
Great.
Yep.
Thank
All
you.
right, brilliant. All right, so thank you for that introduction. That was very, very wordy, I'm sorry. So I have a conjoint appointment with the Uni of Newcastle, and I'm also a clinical psychologist in a psycho-oncology service at the Mater Hospital in Newcastle. And I've just got my co-investigators there, so I'll acknowledge them. And I just wanted to add to the acknowledgement of country that I'm presenting today from the lands, the traditional lands of the Worimi Nation. So anyone that was in the sessions yesterday would have heard about that, you know, the need to screen for distress, anxiety, depression has been really well established in psychosocial care. But there's no real ideal instrument to date. They've all got pluses and minuses. And so one of the new approaches or newish approaches to developing measures is a thing called the PROMISE initiative. So the long version is the Patient Reported Outcomes Measurement Information System. It's a really big project kicked off in the US. And what's kind of a bit different about it is that it uses item response theory to in developing the questionnaires and choosing the items. And so we can't really go into item response theory, but I guess the important thing for us at this point is one of the things that item response theory does is you can have what's called computerized assisted testing, and you can tailor the items that a person gets based on their responses. So you've got an item bank of 30 questions. Someone that answers yes to question 1 might get a different question 2 to someone who answers no to question 1. And so what they're saying is they can tailor the actual items to the person, and so they can reduce the length of the measure. So they're saying that it should be briefer and more precise than other forms of measurement. So the PROMISE, let's see, So the PROMISE measures are getting starting to be quite widely used in cancer. There's a lot more than depression and anxiety. There's a lot more than just cancer in the whole thing. But so they're getting quite widely used in cancer now. There was a recent systematic review, I think something like 31 studies had used it just as an outcome measure. And then there's a bunch more that have done some validation-y things. But they haven't really been properly validated in cancer. So obviously, criterion validity, which is comparison with the gold standard, is the holy grail of validation studies. There have been not many criterion validity studies for the depression and anxiety measures. There have been none in oncology and almost none using this specialized CAT measure. And there's some evidence based on convergent validity, which is looking at whether the new measure correlates with the measure known to have some validity already. So I just put this little slide in here just to kind of point out some of the limitations of correlation, in that apparently the global warming is associated or correlated with a decrease in the number of pirates since 1800. Okay, so the aims of our study were to look at the validity of PROMISE and depression anxiety measures in oncology, with the primary aim of looking at the criterion validity. We did that by comparing with a gold standard or a reference standard, which is a structured clinical interview by a psychologist, a registered psychologist, and we calculated area under the curve and diagnostic accuracy statistics like sensitivity and specificity. We also looked at convergent validity, so correlation with some legacy measures, and we looked at the CAT function to see if it was actually briefer. So the PROMISE measures that we used were the depression CAT and a thing called the short form, which is just like a regular questionnaire, like just 8 regular items that they've chosen from it. And for the anxiety one, we had a CAT version and a short film version as well. The depression measures, the PROMISE measures are scored on a T-score. So they're transformed to a T-score with a range of 0 to 100, a mean of 50 and a standard deviation of 10, using an algorithm based on the US general population. And they've proposed cutoff points of 55, indicating mild levels of depression or anxiety symptomatology, and 65 as moderate levels. And these are the legacy measures. So these were also presented on computer. So we had, I'll let you read them, but briefly, the HADS, the DAS, PHQ, BDI, which is Beck Depression, Centre for Epidemiological Studies, the Psych-6, and the good old distress thermometer. As the reference standard, we had a clinical interview. So registered psychologists interviewed patients for major depressive episode in the last month. So if they met criteria for a major depressive episode in the past month, they were considered a case, and for any anxiety disorder. So they're all the subsets of anxiety disorder that were included in that. So the sample, oh, and I'll just mention that the registered psychologists were blinded to the responses on the questionnaire, so they were quite separate, but everything happened on the same day. So we had 132 oncology outpatients, primarily women with breast cancer, but not exclusively. There was a reasonable range of diagnoses and time since diagnosis. And 14% of the sample made criteria for a major depressive episode, and 28%, so a bit under a third, met criteria for any anxiety disorder. So in terms of the, oh, that's right, the analysis, I'll just reiterate that. We looked at area under the curve, diagnostic accuracy at the proposed cutoffs, and we looked at more if there are any optimal cutoffs. We did correlation for the convergent validity, and we did the CAT functioning. So in terms of results, the criterion validity of the promised depression and anxiety measures was confirmed with areas under the curve all more than 0.80, which is good. The depression measures were in the mid-range of the legacy measures. They're all very similar, 0.81 to 0.86. And the anxiety measures, it was, let's see, less accurate than the GAD-7, but better than the others. So these are the sensitivity and specificity results for depression. So I don't know if my little markery thing here will work. So at the proposed mild cutoff point, the sensitivity was okay. It was a lot better at the optimum cutoff of 53, with sensitivity up to 0.83. And it was really poor sensitivity at the cutoff for moderate depression. And then the CAT was much the same as the short form. There was no real difference in those two. These are the results for anxiety, kind of similar. The anxiety measure was less accurate than the depression measure. And the short form was actually better than the CAT, which was the opposite of what probably should have happened at the mild level, so that 55 cutoff. And again, 53 seemed to be the optimum cutoff score for there. So the convergent validity was confirmed. All of the instruments correlated with each other really strongly, or moderate, yeah, significantly anyway, at 0.001. They had strong correlations with some of the measures and moderate correlations with all of the others. In terms of the T-scores that we got, our sample scored bang on the population average, so 50 as a mean with a standard deviation of 9, and I think the standard was 10. So we might have thought with our population having so many people who met criteria for mental health diagnosis that our mean might have been a bit higher. And we found that the CAT was relatively brief, had an average of 6 items, but sometimes it did, for about a quarter of people, it had up to 12 items. And interestingly, if you're a promise nerd, there were fewer items if you had if you met criteria for disorder. So the more symptomatic you were, the fewer questions the cat needed to make a decision that that it had made a reasonable estimate of your level of symptoms. So these are my conclusions. We've confirmed the validity of the depression and anxiety cat and short form measures in an oncology sample. There weren't any real advantages of the PROMIS measures. They weren't shorter, they didn't have better diagnostic accuracy, with the exception that the PROMIS depression measure is much shorter than the Beck Depression Inventory and the CESD. There wasn't really an advantage of CAT versus the short form. And the CAT is actually rarely used in research or practice. And I suspect that's partly because it's much more complicated to implement. And the optimal cutoff points are to be decided, but they'll probably be lower than 55. So that's it. So how did I go for time?
Wonderful. And we're a bit over anyway. So now we don't have any questions in our Q&A.
Yep.
So now, Jo, I'm not sure whether you would like, whether you've got anything that you were keen to ask. I just thought it was great research, of course, and actually really important to highlight, because it does highlight the ability of the use of various scales as well. So so well done for that.
Yeah, I was just going to ask Kerry. So, given the psychometrics, would you actually recommend that we look to start using PROMIS measures in psycho-oncology, or is it not worth the extra effort to implement?
For me, I think not yet. I think we need to do a bit more on checking on the norms outside of North America and in an oncology population. So if you look at the other research, a lot of people are getting quite symptomatic populations returning a mean of 50, which is just not useful. So for the moment, and there's no real advantage over the really well-known ones. And I mean, if you kind of look back through those slides, sometimes it's not better than the distress thermometer. Yeah. So in terms of screening, I think I would go that way. So if I've got just a quick moment, I just wanted to mention some of the other, the depression results have been published, and the anxiety ones are under submission. And then I just wanted to just mention briefly some of the other work that we've done in like measures. So we've done some studies co-calibrating all the different, this is in terms of choosing, co-calibrating all the different depression instruments. And so if you take a score of possible on the HADS, so that's an 8 or more, someone has to have a lot higher symptom burden to score possible on the HADS than they do to be classified as having mild depression on any of the other measures that we looked at. And the same thing happens for anxiety. So the HADS possible and the DAS-A mild, the HADS and the GAD-7 are similar, but the DAS is higher, needs higher levels of symptoms to be classified as mild. So all the cutoffs aren't equivalent. So in these studies, you can see that like a PHQ score of 10 is equal to a HADS score of 6, is equal to a CEDS-DU score of 21, a BDI of 17, a DAS-D of 5. So we've kind of published those tables. We've also done the distress thermometer versus the HADS. So a HADS-A of 8 is equal to a DT of 6. So it's just interesting in terms of like cutoff points. And we've done some stuff on reducing the problem list, because the problem list is quite long. Like the beauty of the distress thermometer is that it's one item, but then you give someone another 39 items, it kind of makes it much longer again. So we looked at which ones were most distressing and kind of reduced everything down to about 15 symptoms. So I thought I'd just bring that to here as well in terms of choosing instruments and whatnot.
Great work, really important.
And it is quite interesting, because certainly in some other research actually that I'm doing on a 2-question screen, it's been shown that 2 questions is potentially as good as 20. So it's certainly an area that is worth more work from a length of screen perspective. But thank you for that. And let's move on to our final presentation, because we are over time as it is. So Rachel Campbell we have, and Rachel's a postdoc research fellow based at the School of Psychology at the University of Sydney, and today she is presenting on development and validity and validation of the measure of ovarian symptoms and treatment concerns for surveillance, an instrument to complement the clinical follow-up of women with ovarian cancer after completion of first-line treatment. So over to you, Rachel, and great to have you with us.
Thank you very much, Lisa, for that introduction. Can I just check before I begin that everyone can hear me and see my slides okay? Yeah.
Yes,
okay.
All good. Thank you.
Perfect. Okay. So as Lisa said, I'm really pleased today to be presenting on our recent work that has developed a patient-reported outcome measure that's designed to complement the clinical follow-up of women with ovarian cancer after completion of first-line treatment. And so in background, almost 70% of women with ovarian cancer are diagnosed with advanced stage disease. And primary treatment typically involves a combination of debulking surgery and chemotherapy. And following first-line treatment, women are then typically reviewed every 3 months at follow-up consultations. And so the aim of follow-up care after primary treatment for ovarian cancer is to identify and manage persistent adverse effects of treatment, to assess psychosocial and supportive care needs, and to detect recurrence. And clinical guidelines for OC follow-up recommend that patients should be questioned on a range of physical symptoms, so physical symptoms related to their treatment, but also physical symptoms that might be an early indication of recurrence. And they should also be questioned on psychological symptoms. And so patient-reported outcome measures are really ideally suited for this purpose, as they provide a means for standardized symptom assessment in clinical practice. And their administration would ensure that concerning symptoms are assessed routinely and that they are not missed in unstructured clinical consultations. And so the measure of ovarian cancer symptoms and treatment concerns, or the MOST, is a patient-reported outcome measure that was previously developed specifically to assess symptom benefit and treatment burden in women undergoing palliative chemotherapy for recurrent ovarian cancer. And although the MOST does provide comprehensive coverage of symptoms that are relevant to follow-up care after primary treatment, it has not yet been validated for the follow-up setting. And to the best of our knowledge, no PROMs have been validated specifically for the ovarian cancer follow-up setting. And so our aim was to develop and validate a version of MOST suitable for surveillance of symptoms following first-line treatment for ovarian cancer to support clinical follow-up. And we did this by analyzing data from the OPAL study, which was a prospective study of women in follow-up after first-line treatment. And 726 women participated in this study and completed the MOST T35, which is the first and original version of MOST, which contains 35 items. And they also completed several other PROMs, and they completed them every 3 months for up to 3 years. So in order to determine which of the original 35 MOST items to include and exclude in this new version of the MOST for the follow-up context, the author team, which included experienced medical and gynecological oncologists, reviewed the original items to assess the extent to which they covered relevant content. And each original item was assessed against several key criteria. So the first was that items were considered for exclusion if they assessed symptoms that were low in prevalence 3 months post-treatment, which is when the follow-up consultations typically begin, or within 3 months of a clinically diagnosed recurrence. And we, of course, assess the prevalence of symptoms using the OPAL data. We also excluded items that were conceptually similar to another already included item in the MOSE, so that we deemed to be redundant. And the reason for this is that we were really trying to focus on a measure that was as brief and focused as possible, so that it would be optimal for use in clinical practice. And then thirdly, we also considered excluding items that were too general, that could have a range of causes that were beyond ovarian cancer and its treatment. So once we finalized which items we would include in the measure, we then went on to assess their psychometric properties. So first we examined their convergent and divergent validity, which is the extent to which most items correlate with scales from other problems that assess similar content. We also assessed the discriminative or known groups validity of most items. So this refers to the extent to which most items could accurately discriminate between different clinically distinct groups. We also examined the longitudinal validity of the measure. So in other words, whether the measure was responsive to clinically expected change over time. And then finally, we assessed the accuracy of selected most items in identifying clinically important symptoms. And we identified threshold scores or cutoff scores for these items that identify clinically important symptoms that should be further investigated in clinical practice. And so I don't have time within this presentation to go into the item inclusion and exclusion process in detail. So if you're interested in that, I recommend you read the paper on the development and validation of this measure. But I just want to show you here what the final product looks like. So this is the MOST S26, and it consists of 26 items. So you can see here that it has a very simple format. It uses a 0 to 10 rating scale, and items are rated with respect to the last 3 to 4 weeks. So 17 of the MOST items can be used to generate 5 composite scores. And the first composite score is the MOST Abdo, which assesses abdominal symptoms that might possibly signify recurrence. The second composite score is MOST NTX, and it assesses symptoms of peripheral neuropathy. The third composite is MOST DORT, and it assesses symptoms that can be caused by either recurrent disease or treatment. The fourth composite assesses psychological symptoms, and then the fifth assesses well-being. And we also included 9 individual items, which we thought were important for inclusion in the follow-up context, and they assess trouble concentrating, treatment-related concerns, which is important for women who may be on maintenance therapies. And we also included additional items that provide space for women to list up to 3 additional bothersome symptoms and rate their severity. So with regard to the convergent and divergent validity, as you can see here, most S26 index scores were moderately to strongly correlated with scales from other problems assessing similar content. And generally, these were also the highest correlations for each most S26 index. And with regard to discriminative or known groups validity, as you can see here in these box plots, expected gradients were observed in the distribution of scores for most items assessing anxiety, depression, fatigue, and trouble sleeping, across clinically important thresholds for the HADS, the facet fatigue, and also the insomnia severity index. And we also found results that were similar to these for most items assessing peripheral neuropathy and well-being across important thresholds for the FACT NTX and the FACT G. So in terms of responsiveness, we found that among women who reported at least some neurotoxicity at baseline, all MOST indexes were responsive to expected improvements in peripheral neuropathy, disease or treatment-related symptoms, psychological symptoms, trouble concentrating, and well-being, and approximately 12 months post-treatment. And also with regard to longitudinal validity, we also found, as expected, that the MOST Abdo detected a worsening of abdominal symptoms within 3 months of a clinically diagnosed recurrence. So finally then, ROC curve analysis for selected most items indicated excellent discrimination for these items. And we identified that threshold scores above or equal to 4 for the item assessing anxiety, 3 for the item assessing depression, 4 for the item assessing trouble sleeping, and 5 for the item assessing fatigue were identified as clinically important thresholds. And so that patients reporting these scores should then receive further attention and be and further investigation in clinical practice. So in conclusion, the MOST S26 is a patient-reported outcome measure that was developed specifically for surveillance of symptoms following first-line treatment for ovarian cancer. It assesses peripheral neuropathy, disease or treatment-related symptoms, abdominal symptoms, psychological symptoms, and aspects of well-being. The MOST S26 is dual purpose, so it can be used in research contexts to assess outcomes of ovarian cancer follow-up care from patients' perspectives. And it can also be used in clinical practice to identify troublesome symptoms early, hopefully leading to timely referral and appropriate intervention. And it can be used to track trajectories of symptoms between clinic visits. So the paper describing the development and validation of this measure has recently been published. So if you are interested in reading about this in more detail, then the details are shown here on this slide. And if you'd like to access a copy of the MOST S26, it is hosted on the Gynecological Cancer Intergroup website. And the link to that is also provided here on the bottom of the slide. So thank you very much for listening. And I look forward to answering questions if there are any.
Wonderful. Thanks so much for that, Rachel. It does look like it's going to be a really useful scale. One thing that I was wondering was, so it's obviously been developed for ovarian cancer, and so without actually having a look at it in detail, did you have any plans to translate that over to different cancer types? Do you think that it's the type of scale that would actually have translatability?
No, I don't think so, to be honest. I think that the measure has really specifically been developed with ovarian cancer in mind. And so it may well be relevant to other gynecological cancers or other cancer types, but we don't have any specific plans to use it among other cancer types. It was really developed with a specific focus on ovarian cancer.
Fantastic. Well, thank you very much for that. It looks great. Now, I just actually wanted to go back and ask a question that was for, let me just find it. For Courtney. Is Courtney still with us? Yes. Courtney, do you mind answering another question? There was just a question in that was put in the chat, so I missed it. So apologies. But so it was a question by Jo Fardell, and so she says, thanks for an interesting talk. Do you have any plans to also include behavioural testing in your mice?
Yeah, so I had a bit of back and forth with Jo in the Q&A, I think, but we are planning to try to do some behavioural testing. We've found that our mice aren't very cooperative, and they don't really like to do what we would like them to do. But I think that's also because they've just had chemotherapy and they're not feeling the best that they've felt. So she had the suggestion of doing a dose or cyclic treatment with them to see if they'd feel a little bit less or a little bit better than what they do with the single bolus dose, and see whether we can get some behavioural outcomes, which would be great to look at.
Fantastic. And I'm glad that you connected with her on that. That's great. All right. Well, thank you for all of the amazing presentations that we have had today, and apologies that we have gone a little bit over time. It's difficult with such a tight schedule to stick to the schedule, but certainly big virtual round of applause to all of our wonderful presenters that have been able to talk about various areas of survivorship related research today. So Joe, unless you've got anything to add.